Great. Hi, everyone, and welcome to this session on how immunization supply chain contribute to reaching zero-dose communities. This is the third and last session of this webinar series. Today, we're discussing integrated supply chain approaches to reach underserved zero-dose communities with vaccination and PHC services. I think I forgot to activate the chat, so let me do that very quickly so that you can use the chat and introduce yourselves already. As usual, we are recording this session, and we will share the links to the recording as well as to the slide. Also, please note that this session is interpreted into Spanish and into French. So you can listen to this presentation in French or Spanish by clicking on the globe at the bottom of your Zoom window, and you select the language you desire. I think we are ready to start, and I wish you a pleasant session. I give the floor to Olamide. Olamide, the floor is yours.
Hi, everyone. Thanks, Alex. I hope you can hear me okay. Alex?
Yes, that's fine. I will let you know if there's any issue.
Thanks very much. Thanks again, everyone, for joining us. Like Alex said, this is the third in the series of this webinar on how immunization supply chain can support in targeting and reaching zero-dose communities, zero-dose children. And you remember we started the 9th of February with supply chain guidance and strategies. On the 16th, we looked at best lessons and best practices from countries on reaching and targeting and reaching zero-dose children. And today, like Alex said, we're going to integrate supply chain approaches to reach underserved zero-dose communities with vaccination and PHC services. We have as usual, start-coded panel today. We'll start with a few high-level updates overview from UNICEF headquarters, and Ranjit Diman, Senior Manager Supply Chain and Logistics, would be handling that. And then we'll have country experiences from Lebanon, Dr. Brigo would share first, and then Douglas from South Sudan, both from the UNICEF country offices. So sit back, relax, and we hope that you come with questions as you did in the first two webinars. And hopefully at the end, we'll summarize all these three webinars and look at next steps. So without further ado, I'll pass on to Ranjit.
Thank you so much, Olamide, and really happy to be in this webinar, connecting to all of you on this subject of zero-dose communities and how primary healthcare services contributing to and linking to zero-dose. So today I'll pick up the topic of health facility solar electrification, and this is where we as UNICEF, of course, I'm coming from UNICEF, so I'll give a little bit of introduction from UNICEF side and take all of you through global agenda and alignment with the direction UN SDG goals are aligning with. So electrification of health facility is contributing to SDG 3, good health and well-being, by improving the primary healthcare services, and then SDG 7, which is affordable and clean energy at the health facilities, and climate action, SDG 13. So that's the one intervention leading to having improvements in these three SDGs. And as I said, coming from UNICEF, I would like to bring up very high-level roadmap for us, where we are leading to, and just to give a high-level picture, strategies we are looking. One of the strategies, resilience and preparedness, as you can see, to reach three goals: catch up and cover, leave no one behind, and strengthen and sustain. And they are all interlinked. And leave no one behind is probably taking us to zero-dose community and addressing the problem there. And primary healthcare infrastructure is strongly linked to sustain and strengthen the primary healthcare services, and that's where we are coming in. Coming to next slide, please. So I'd also like to draw your attention to WHO's and alignment overall with UNICEF and under the umbrella of healthy environment for healthy children. We are looking at the climate resilient primary healthcare infrastructures facilities, and coming in from climate change issues, the resilience need to be for sustaining the facilities so that the services are provided. And then we are looking at within the healthcare facility improving the health workforce, which is essentially human resources, capacity development, communication, of course, water, sanitation, big agenda, waste, healthcare waste monitoring and assessment coming within that, and energy is one of the big primary intervention there, and improving the access of energy. And within infrastructure, technologies, and product, we are also looking at digitization when as we are reaching with solutions with the energy of health center. So all these components adding up together to leading us towards the SDG 3, which is better health and reducing all the burden we have. Next slide, please. So coming from, let's say, within what we want to do in terms of how we are going together with multi-agencies, where we have WHO, Gavi interlinked in between. We have a global fund, we have a World Bank, and many and CDC. We are looking at solutions in 4 big baskets. Solarization, which is using the energy from solar and powering health facilities. And of course, this is coming in. Can you do one more click, please, to bring the text below? Yeah, for some reason, text is not visible. Yeah, so maybe, so no, it's gone already. Previous one. Yeah, for some reason, text is missing. Solarization, maybe I can speak to that. Solarization, we as UNICEF and Gavi, and of course, many agencies contributed to improving immunization through solar direct drive, implementation of solar direct drive in remotest part of the world. As we speak today, about 80,000 fridges have been deployed globally. And that's the experience we are counting on, we are banking on to expand the services to full health facilities. While we are reaching out to the remotest part of the world with a fridge and a solar panel to power the fridge, we very well be able to expand the energy to the health center. So by expanding the energy to health center, what we achieve is providing better opportunities to, let's say, improve the maternity services as a starting point, better OPDs. We have laboratories and primary commodities, PHC commodities that includes oxytocin, insulin, and other commodities that requires refrigeration, other commodities that can be integrated with last mile, let's say, delivery of last mile to these centers. So that's the solarization part, where we talk about bringing energy. And then within the wash component, of course, we have a solar pump, and then there's been about more than 3,000 implementations done globally. And then some of our colleagues is going to share this experience overall in these 2 areas. And then we are also looking at waste management, which means essentially improving the reduce, recycle, 3R components, recycle, reduce, and reuse principles at the health center, minimize the waste, segregate the waste, improve the health impact of exposure to exposure of waste to the health of children, exposure of infectious commodities to the health of health workers. So all that is management at the health facility, but then taking the solution to the next level, where we talk about immunization waste overall, COVID-19 waste, the burden added by the vaccination, PPE kits, and name the thing. It has exposed the problems more clearly than it used to be, and then overall primary healthcare waste. So we are looking at solutions of addressing these three together, bring up and have solutions for the country. Workforce, of course, a lot happening in terms of improving the capacities of frontline workers, providing them better facilities, and solarization is again linked to that, where we talk about when we bring the energy to the health center, we are also talking about having energy for their staff quarters, for their well-being, so all this is interlinked and adding to the goal of having better primary healthcare services. And then just one more slide before I hand over to our colleagues from Lebanon and South Sudan who are presenting today their experience in solarization. Just wanted to bring up this interesting slide which talks about what's the current demand we see globally from all the regions of the world. So as we talk today, about 47 countries express the demand of solarization, where we look at the access to energy. About 59% of the health facilities do have electricity, and it's reliable, suitable, but other half does not have. And from the other half, about 30,000, 28,000 is one step. We have more updated number. About 30,000 health facilities are in need of electricity today. These facilities can be solarized and will have high impact of improving services. So these are high impact facilities where if we reach out with solarization, we will have low hanging fruits. And of course, there is more 42,000, 45,000 health facilities which do not have electricity, and they will also benefit as we go. So prioritizing the needs, 30,000 health facilities is immediate demand. And looking at this demand, we have solutions already being implemented. Many countries I can name out, they are in advanced stages of finding solution one way or other and implementing solutions. And that's where our colleagues from Lebanon are going to talk about this, and South Sudan. And with this introduction, I would like to hand over to Brigu Kapuria, Dr. Brigu Kapuria. He's from UNICEF and based in Lebanon, and he'll speak to you about what solutions they are and what experiences they had already on solarization. Over to you, Brigu.
Thank you, Ranjit. Thank you so much. And very good morning, good afternoon, and good evenings to wherever you are, in which part of the country you are located. And thank you for providing this opportunity to share the experience on what Lebanon has been doing it. So, okay, what we have done is, because, and I'll explain it in my slides, how we are trying to use the immunization as an entry point to ensure that the primary healthcare services and immunization services are continued in this entire extremely tough situations that the country is going in from. If I talk about Lebanon, let me introduce you to the country to this. So the context, setting up just the context, Lebanon is a small country which is located in the Middle Eastern part. And you might have heard about the culture, the history, and the food. Lebanese food is a very famous food all across. And this was an epicenter of the entire Middle East part on healthcare, on education, on trade, on tourism, different pieces. Lebanon has come out from a long civil war from 1975 to 1980, and then rebuilt itself to become an upper middle income country. So it has gone through its full journey and is now is into the transition of taking it forward. If we look into the Lebanon context, the current situation is that Lebanon is going through an extremely bad economic crisis. World Bank has described this as the worst economic crisis of modern history. And just to bring in some figures and facts, the inflation rate currently is at 172%. The economy has shrunk down at 58% between 2019 and 2021, which is the largest shrink across 193 countries. The local currency has lost 97% percent of its value, and 82% population have come down into the multidimensional poverty. And with all these sad things, World Bank in 2022 reclassified Lebanon from an upper middle income country to actually a lower middle income country. It is also important to note that Lebanon hosts one of the largest refugees per capita in the world. So the largest number of refugees per capita that exist in anywhere country is Lebanon. And this economic crisis has extensively pushed the refugees also, whereas 89% of refugees are now living into extreme poverty. This is the rate of inflation. If you see, the problem is that this entire thing happened so rapidly that between 2019 and 2022, the entire situation has changed across and it has moved. The impact of all of this has three major pieces that I will be dealing now. One is on the fuel prices. There is nearly tripling of fuel prices within 1 year. So when the fuel prices tripled, everything has gone very expensive. The second piece is electricity. The country is practically running in dark. At the national capital of Beirut, we have less than 1 hour of grid electricity per day, and practically no electricity exists. So what is happening is everybody is trying to generate their own electricity if they are able to using diesel generators. So and the entire country is practically running on diesel generators. And when the fuel prices become triple, everything goes out. And to add to compound to that is when the dollar value and the currency value is lost, the budget of the national health program is practically is minuscule. If I go to the impact of this on this entire crisis on health and immunization, it is important to that when the crisis started, nearly 40% of doctors and 30% of nurses left the country. So there is an extreme shrink of human resource that were there. And this country used to run on private sector. So it has a very big private sector, which suddenly became neither affordable nor accessible. So this led to a drop of nearly 30% in the immunization coverages in public sector and nearly 50% drop in the private sector. So immunization became a point where people tried to avoid vaccinations, delay vaccinations, and not go forward for vaccination. All of this has led to severe risk of outbreaks of VPDs like measles and diphtheria. Because of our surrounding and this, we are already part of a threat of polio, and we had multiple episodes. Just to say that in this country where there was no cholera returned after 29 years, and we had a full cholera outbreak because of collapsing water, sanitation, and health structures. So this is just to represent overcrowded health facilities whichever are running, and you can see a country who was well into the good immunization coverages with DTP coverages more than 82%, with measles 1 dose coverage running high, suddenly dropping down to values which is less than this. And what it has led to is that what it has led to is that every third child in the country is now a missed child. So every third child has missed their vaccine, and every 10th child in Lebanon is a zero-dose children who has not received this vaccine, any kind of vaccine, which was not the circumstances few years back. So as I said, the challenge is over compounding because the public sector was a limited service provider. Nearly 40% of immunization was provided by the private sector. The EVM score that we did in 2021 were at 63%. You will be surprised to know that more than 80% of cold chain equipments in Lebanon used under the public health facilities were non-WHO pre-qualified, which required an urgent replacement of the entire inventory because every vaccine was being stored in domestic fridges. The other piece was that because these are old generation fridges and because there is no electricity, many facilities have now switched to use gas or kerosene because there is no electricity. And the facilities which practically were running across are now using diesel generators to serve their pieces. So if you see the equipments and the inventory, it is domestic refrigerators which are being used, facilities providing services in total dark, and services vaccines being delivered in different forms and settings. So we developed an action plan. We developed an action plan to identify what are the things that can be done jointly. So we devised a two-pronged strategy. The first strategy, which was immediate and urgent, was to safeguard vaccines because of the non-electricity, because of non-standardized fridges, because of fuel consumptions and fuel challenges, our vaccine safety became the action one and the priority number one to run across. To do that, to do on those interventions, what we started was a full replacement of the entire cold chain inventory to make it clean, green, and environmental friendly, and to have solar cold chain equipments working on these equipments. Sorry, the slides are not moving. I'm trying to. Let me project it from my side.
Let me know if you have any technical issue, if I can help.
I think it is the connection problem that is happening over here, but can you see my slides?
Yes, we can. Can you make it full screen, please?
Yes. Is it full screen and visible on?
No, it's not full screen. If you go to display settings at the top of your screen, top left.
Top left, yes.
Show taskbar, and next to it, display settings. Next to it, on the right, à droite. Display settings. Do you see it? No. Next to, okay, where you are, but next to it, on the right, display settings. Don't you see it?
It is creating a. Yes, display settings.
Voila. So click on it and change it.
To duplicate?
Try duplicate slideshow. I don't know if it's the first one. Oh, try the other one. Yes, it's working. Thank you.
Are you able to see the screen?
Yeah, full screen. It's all good. Thank you.
Okay. So
it's not good anymore. It's left. Click on the full screen again at the bottom right.
Is it now?
No, it's not. Yes, go ahead. Yes. Okay, it's working now.
Okay,
Good.
it's working. Perfect. Sorry for the delay, and I'll try to compensate on being fast and clear on that. So we developed two action points. The first action point was urgent and immediate, where we had to safeguard the vaccines, and the second was to safeguard or sustaining the immunization and primary healthcare services, because both of them were getting impacted. So on the action point number one, which was safeguarding the vaccines, what we did was, because our entire cold chain inventory was running on domestic fridges, it was running on non-WHO pre-qualified. So we had to replace and we had to bring in standardization. So when we are doing that, we brought in the saying, using instead of using gas and kerosene for this, we switched on from, if you can see these fridges which are running on their gas because there is no electricity, we switched it to WHO. We made it a point to do it clean, green, and WHO pre-qualified entire cold chain network. To do that, what we started with the central warehouse where the entire vaccines were stored, we solarized the entire central warehouse. Then there were 14 district offices or KADA offices that we call. We solarized them so that the district vaccine stores are also solarized. And then we have a replacement plan of nearly 900 plus non-qualified fridges with the solar direct drive. So this was there. What we target is by the end of June 2023, our entire network of cold chain equipment which are storing vaccines wherever it is feasible will fully run on solar, well connected with remote temperature monitoring, so that even in the adverse of circumstances, vaccines are safe and are secured.
Dr. Bregu, sorry to interrupt you. Could you please slow down a little bit for the interpreters?
Sure.
It's very fast for them. Thank you very much.
Okay,
sorry.
Thank you. So if you see, this is a picture that summarizes what we have been doing. We have moving in from domestic fridges to solar direct drives. We have been working on solarization of bigger warehouses and bigger stores, and bringing in the solar cold chain equipment for this. The step 2, or the action point 2, was to ensure that while we were able to materialize the what do you say, vaccine storage, the service delivery was all a big challenge, because not just for vaccine storage, but for the facilities to provide services, they didn't have electricity, and they were initially running it on generators. It is hard to imagine for somebody, but the entire country is running on diesel generators, and there is no grid electricity at all. So people who were able to, or the facilities which were able to do that, were continuing to provide services. But when the fuel crisis happened, and when the fuel prices became 3 times, facilities had to shut down their diesel generators also. So now the services were either being provided in dark, or the services were stopped, reduced, or compromised. So here, the second piece that we used immunization as an entry point. And we said, when immunization could be an entry point, not just for providing immunization services, but also to ensure that primary healthcare services are ensured. In that effort, what we did was we started an initiative, and we started managing with donors to ensure that if we can go ahead with solarizing of the activities, and finally, with support from donors, we were able to start the process of identifying 150 primary healthcare centers which are providing extensive services, and get them solarized, so that you have the vaccine safe, and you also have the services that are being done by the health centers that can continue to provide there. In that, the step 1 was assessment of feasibility and energy needs. In PHCs in Lebanon are located in various locations. It is not very clear. It could be located in a multi-story building. It could be in a rented place. It could be a standalone facility. It could be a shared facility. It exists in multiple forms. So while we are trying to solarize, it is not easy that you can go and solarize anyone else. So in that, we started doing an assessment of feasibility, whether solarization is actually feasible or not, and also conduct energy need of what is the need of every facility to run critical steps. Here, our UNICEF PG team at headquarters very clearly and very efficiently supported us in developing a comprehensive assessment tool. How do we assess them? Also helped us in developing an energy audit need system to identify what it is there, and then finally provided us to support establishing long-term agreements with solarizing companies, so that we can actually fast track the entire process. So I thank the entire team and we completed the assessment of 275 facilities and identify 150 facilities which are fit for solarization. We also established LTAs with 4 national solar companies, so that the solarization process can start. And the solarization assessment had all components which ranged from what is the visibility, what are the infrastructure, how is the rooftop, what are the components of that. And as a step 2, from first week of March, we are actually going across solarizing these 150 facilities with a target to complete the entire solarization within 12 weeks. As I said, is part of the feasibility assessment. Every component, which is whether it's building pieces, rooftops, constructions, flooring plan, all of that was collected. And this became a robust database, which the ministry is now using not just for solarization, but for also prioritizing many other services. I will stop saying my presentation by saying that what we are doing is we are trying to use immunization supply chain and immunization services as an entry point to ensure that services are delivered, vaccines are safe, and primary healthcare services are maintained, so that no one is left behind. Thank you so much. I'll stop sharing my screen.
Super. Thanks so much, Brego. I think Olamide continue to have issues with internet, so probably I'll step in. Olamide, if you're there. Right, so we have issues. Maybe we pause here and see if there is any question. I can see some questions in question and answer section. Anyone want to ask any question at this stage? Alex, how does it work? People can ask question only through chat, or
okay. So apologize for our participants our main moderator has some technical issues with his internet connection. So for the Q&A, you see the Q&A box at the bottom of the Zoom window. You click on it and you have access to the questions. I see Michelle is replying in written, but don't hesitate to just read the question and perhaps answer it, unless you want to answer all the questions at the end of all the presentations. I think that's normally the way we usually do, but I'll let you decide.
Alex, yeah, let's proceed with the rest of the presentations and then we can have a general discussion because there aren't that many questions as yet.
Okay, excellent. Let's do that. Thank you, Michelle. I'm not sure who's next, Michelle or Nicholas. Okay, Douglas. Okay, so the floor is yours.
Thanks so much. Yeah, Douglas, is that yours? Sure, go ahead. If you can do a full screen. Slideshow.
Okay, I hope you can see the slideshow. Regina, please confirm.
Very well.
Okay, so good morning, good evening, colleagues. I'm here to present on behalf of South Sudan in regards to the sterilization project that's taking place in South Sudan. So I'll be a bit fast in terms of time. So South Sudan is, as most of you know, should be one of the youngest countries in the world, with a population of around 14 million and 10 states, 80 counties, 540 payams, which are like districts, and it's bordered by Uganda, Ethiopia, and Ethiopia, and I think Chad on above. We shall get to know that later on. So I just want to give you this background of and the numbers for South Sudan. In terms of the background, South Sudan is the least electrified country in Africa, with access to electricity at 7.2%, according to the World Bank report. So you will see that most of the facilities don't differ too much like from Lebanon. They are run using electricity, meaning that it's a lot of energy that is being used. And like the first presenter said, that one of the SDG goals is to have affordable energy. So UNICEF South Sudan has gone into a sterilization project, which is funded by World Bank and HQ. And UNICEF's role here is to implement the project of electrification of some of the facilities that have been chosen. And the choice of facilities was done based on facilities that have got delivery of comprehensive emergency obstetric and newborn, because this is where the newborns are. These are the hospitals that carry on newborns, and it's taken care of mothers that probably give birth in the night, whereby they don't give birth in the dark. Currently, the project is designed to provide solar power again to the national vaccine store, the 10 state stores as you show them, the 35 health facilities, and 22 county hospitals. That's the broadness of the project, depending on the funds that are available. So how has the sterilization improved the immunization supply chain to reach the 0 dose? One, the sterilization has provided access to primary health care services beyond the normal times in the country. As you all know, as I mentioned, that only 7.2% of the country has electricity, meaning that with having sterilization at the facilities, the services can go beyond the normal times of when the darkness comes in. Again, it has led to reduction in terms of the cost, which also has led to seeing stockouts coming low, especially at the health facility levels. Remember that when you're running the generator, it means that once the fuel for the generator goes away, then the fridge will go off. And we're not so sure probably when you get the next shipment of the fuel, then the vaccines in the health facility, either you have to transfer them to another facility or they have to go to get bad. But with the sterilization, both of the equipment and the facility means that we shall have power which is 24/7, so there won't be any interruption in terms of vaccines, thereby reducing on the number of the missed opportunities and because the stockouts will have been limited. The other issue that has ensured is the quality of the vaccines. This also goes together with almost what I've just explained, that the quality of we are rest assured of the quality of the vaccines, as solar equipment won't go off like any other equipment that is available. The other point is building the resilience. Solar energy has contributed to more resilient health systems. Reliable power has ensured that core systems of the management of health programs are kept functioning. This is one of the things that is really being seen that is coming up with the solarization. It's noteworthy thing that investing in sustainable energy, as mentioned before, that the country is driven by generator electricity. But of course, once we go solar, it means that the country will have more sustainable energy. And those of you who know South Sudan, it's like most of the EPA program is donor driven, and the country's contributions are quite too little or not even seen. So by us running to solar, it means the country will have some form of sustainable energy that the government can run in case of if government takes full control of the program. Again, furthermore, this energy has helped in terms of use of data for action. As you know that we're gradually moving away from the manual SMT, moving to the SMT, which is electronic, meaning that we shall require computers for us to be able to manage our data, monitor the data, and then also transport the data to the higher facilities. So with this kind of system, the solar energy is helping us to ensure that the facilities have adequate power, such that the ESMT can be used and for its purpose. The other thing that we've seen is the urban social development. You know, with solarization, most of the you find that most of the well-to-do families probably would prefer to run to the center or to the capitals of the states, whereby they can give birth, where they will get proper services. But since that some of these facilities in the urban and the rural settings are being solarized, it means that we're seeing more mothers coming to the facilities to give birth, because of if it is rest assured that even if I give birth during night, there will be somebody to attend to me. So meaning that if somebody gives birth at the facility, it means it will be able, we shall be able to capture that child and probably get the initial doses that are required, like BCG or PV0 at any one time. Meaning probably it will help in improving also the coverage, because of seeing more mothers that are coming to the facilities for services. So this is one of the facilities that has just been solarized, it's Boma Health Facility. And you see the difference that right now at night there is light. This alone is something that can pull mothers to come to the facility to get services. And these are the picture on the top right is one of the solar fridges that we are using. It's an SDD that also is helping us to really ride out all the electric and probably kerosene fridges. And the plan is to go green, and of course by SDG 7, which says affordable and clean energy. So that's the plan. In terms of the lessons learned, of course, one of the things we've seen that we've installed some remote monitoring systems to the solar sites where the installation has taken place. So these remote monitoring systems help us to give real-time data in terms of the functionality of the solarization, the facility that has been solarized. So once this data comes in and there's a problem, it means maintenance period will be reduced, because we shall get real data and know that this equipment needs to be maintained or there's a fault, then we can address it easily rather than waiting for reports that come down from the field. The other thing also is sourcing for equipment locally. This is part of the lessons learned, or part of the challenge has been quite challenging, especially the solar batteries. These are batteries that cannot be got local on the market. They have to be imported. So, and the time frame we are given to deliver this project was quite short. So it's one of the lessons that we've learned. But next time probably we can include in international companies to come and support us in terms of the installations. Of course, nothing goes without challenges. We've also seen some challenges as we're trying to implement the project. One of it, in terms of the ESMT, is the capacity of the staff down there to manage the electronic stock management tool. It's got that challenge. But again, when you look at the number of facilities in South Sudan, and you look at the number of facilities that the project is going to support, it's only like, I would say 5% of the health facilities will benefit from this, meaning that we still have a long way to go. And the other challenge that we've got is the decommissioning of the old equipment. As all of you know that most of the fridges, electric fridges, some of them are still using the CFC gas, which is not ozone friendly. So we don't have proper guidelines on how to decommission of this equipment. There's lots of investment that has been done from CCOP1, CCOP2, so we're going to CCOP 5.0. We also had the COVAX CCOP, which brought in a lot of solar direct drive fridges. But the problem is now we have a backlog of old equipment which is not disposed, and probably shall need some guidance from the office or from headquarters to see how we can support the country in terms of decommissioning of this equipment. The other challenge that we are foreseeing that will come up is that there's no clear guidance on the sustainability of the program, because you know that when donors come, when funders come, they will give you the initial cost of procuring the equipment, installation of the equipment, but now the recurring cost in terms of maintenance, the spare parts, it's something that is yet to be cleared. But that's something that we are seeing that otherwise, because if we don't have a proper structure in terms of the maintenance and the spare parts procurement, it means all this big investment can easily be run down within a very short time. So those are some of the challenges we've seen. So the way forward, in terms of the way forward, we are planning to digitalize the microplans, and this is the strategy that we're trying to see that will help us also to reach the 0 dose when we have the digital microplans. But of course, these microplans will be integrated, not having just a microplan for API, but we're trying to see, because all of us are looking at the same child, how do we integrate this microplan to include the nutrition, to include the child protection, such that at least to make sure that this child is registered at birth, to include the nutrition package, and of course the API package. So with the digitalization of the microplans, that is something that we're looking forward to see. In terms of the maintenance, also we're trying to see how best we can have some companies or some support to see how our technicians that are managing the normal solar fridges can be further trained to manage the bigger solar systems, to be able to back up that, as we also try to bridge the gap in terms of the spare parts procurement. In terms of expansion, we're trying to look into all sorts of maybe donors that are coming up and proposals, then to try to sell this. After getting the lessons learned, we want to come up with probably some document that we can use for donor relations to show where South Sudan was and what have been the fruits that have been brought after solarization of these facilities. Then we can weigh and see what are the pros and cons and sell out this idea. Probably we shall be able to move from the 5% and see us moving upwards. In terms of the operation costs, I think I've just mentioned about that, the non-CFC equipment that we're trying to pull out. And the other thing also we're trying to do is to map the health facilities, mapping of the health facilities with the support of the routine immunization coverage data to ensure that the cold chain equipment is equally distributed. So we're trying to get into the map and see how is the coverage vis-a-vis the cold chain establishment, to see if the coverage good in locations where they got more equipment, or is the coverage bad. So we're trying to do some kind of analysis. As I told you that the investment has been quite versatile in terms of the SDTs that have come in. So we want to see how do we relate that to the coverage of the country and look into how the different counties or different PIAMs are performing vis-a-vis the cold chain equipment. I think this should be the last slide. This is the Boma Health facility that I was showing you. It shows us how it was before, the picture on the extreme left down. Then the next picture shows us when the installation of the panels has been done, the technician doing the work on the right. Then the dark one, you see at night how the facility looks like, because before it was really dark, but now you see that there is light, which really is impressing the communities and letting the communities come in for services at any one time of the night. Once again, thank you for providing me the opportunity to share the experience of South Sudan in terms of solarization. Thank you, and over to you, Ranjit.
Thanks so much, Douglas. I think we should move to question and answer session.
Okay, great. So I think we have a number of questions that have come up in the chat, very interesting. And I want to thank the presenters as well for the efforts that they have made. From Asha, there's a question on how are countries selected for demand for solarization, and does the country have to express its interest on solarization, or are there set criteria? And I want to ask Ranjit if he'll answer that. Ranjit?
Sure. So right, so since we're talking about 0 dose, and we are strongly linked to immunization, and SDDs, for example, were rolled out. 80,000 SDDs were rolled out globally because these facilities do not have electricity, and the definition is that you must have more than 8 hours of electricity to have an ILR, electric fridge. Otherwise, a solar solution is more suitable. So we reached out to immunization teams globally, of course, and they responded with a need. So this need, what we're seeing demand, what we're seeing from the country is purely from improving the primary healthcare services, taking the immunization route. And if we, of course, if we expand that list, the demand is 70% of the health facilities globally do not have reliable electricity. So we are going step by step. The first step is really low hanging fruits. So I hope I answered the question.
Super, thanks. So there are actually quite a few, and I will sort of ask maybe Douglas and Ranjit to answer, to come in with these ones as well. On the average setup cost, as well as Brigo, on the setup cost for solarization of primary healthcare facilities according to previous experience. Now, together with that, I think there is also a question on whether a supply division has a valid LTA as well, which I can confirm we actually, UNICEF does. So Ranjit can speak to some of the benchmark costs that we have concluded there, and then I think Douglas and Brigo can also speak to their experience on the costing side if they have that information available. Otherwise, we can always share it after the webinar as well. So Ranjit, over to you, then Brigo and Douglas, if you want to come in.
Thanks so much. So costing is, as you can imagine, it's highly contextual to country situation. Lebanon, for example, South Sudan is one story, and other country where it is locally produced, the hardware is locally produced, locally available, sourced, easily available. The story is different. For us, I can say the cost of solarization has gone down drastically because of increased market, because of increased number of manufacturers coming in. What we were experiencing 2 years ago and the cost we have today, and another thing I wanted to bring it out in terms of context is the size of the facility. So if I take a size of 5 kilowatt package, which is sufficient to run all the lightings, fans, basic needs of a maternity ward, light, suction pump, a baby warmer. This 5 kilowatt package today, hardware itself is costing probably about in the range of $13,000 to $15,000. Plus there is transportation component, which is contextual, and a service bundle component, which is installation and maintenance for a couple of years, is contextual. And adding that together is, I can say it is one cost today. What we experience today is 1/3 of what it used to be 2 years ago. And yeah, Brigo and maybe I can, before going to Brigu and before going to Lebanon and South Sudan, I can come in for LTA. So these LTAs are very freshly established. It is now this month. We have concluded, supply division has concluded the LTAs. We have LTA from 10 different supply system integrators for supply of goods, and also LTA for service bundle component. So which means when there is a need to supply the goods to a country, supply division would run a secondary bidding for the service bundle part, and combining them together, we will have a full comprehensive cost. So yes, we do have LTA now. Over to Brigu, if you want to add to that, and then to Douglas for your local cost context.
Thanks, Ranjit. So what you said was the first 2 points are very absolutely right. One is the local context. In our context, if you see, because there is no electricity, the market towards solarization has gone on. So there is in-country capacity of solarization that exists. But this has, with the rising prices that are there within the country, it has a kind of a relationship where the cost absolutely fluctuates between different variables. But the second piece that you also said is also contextualizing what is the need of the facility. When we did the assessment, and I would like to stress again on that, is that this assessment was actually a very clear eye-opener for not just us, but for the entire ministry, because the energy needs ranged from 2 kVA to 40 kVA. With different health facilities providing different kinds of services that are there. So it was very essential, and then we took across and to identify which are the basic essential things that we run across. And Ranjit, the cost in Lebanon will also run across the same things. If we talk about a 5 kVA, it will run between $10,000 to $13,000, which is exclusive of the maintenance part, which is this, but this is the approximate cost. And these costs are changing very variably. We are trying to ensure that the products that are installed is as per standard procedures, and UNICEF is providing those clear guidances to say what could be the right process of selecting those things, but that remains the cost over here. I'll request Doug.
Thank you, Brigu. Douglas?
Yeah, thanks, Ranjit. I think it doesn't vary too much, like you said, in terms of the procurement, like what many manufacturers coming up. But the issue at hand here is when you look at the size of the facility, we need to look at how much equipment you need to power, because you find that sometimes you need to power up the lab. So it means you have a bigger KVA system. Then, of course, there are other strange things that are probably like you may find that the facility in the village, the health workers leave the facility and go to sleep to town. So we also put mind up to power up the facilities of the homes of the health workers. But for South Sudan, the biggest problem is the transportation. Most of the facilities, almost of the states, will go by air, meaning that you have to put all this heavy equipment onto a plane, probably which is chartered. So that's what inflates the budget to go slightly higher than the normal. But in terms of the procurement, it ranges between 15 to 20,000, depending on the kilowatts that you want. But the transportation comes in as the biggest challenge. So somebody who does the assessment needs to be good before the BOQs are procured, developed. Thank you.
Thanks a million for those comprehensive answers. There's another question in the chat about asking, and the question is, could you highlight how solarization will impact on climate change? And I can take that one. So solar is natural as a concept, is natural energy from the sun. So converting that into electrical energy means we are moving away from fossil fuels. But another thing that we have done with the evaluation of the service providers in the supply division LTAs was also evaluating their supply chains and ensuring that they are their contributions to the SDGs in terms of making sure that they are contributing contributing to those, that they are sourcing locally or as close to source as possible, to also reduce carbon footprint as well. So I think there is a very big focus on that in order to make sure that we are not increasing our carbon footprint as well. So, I hope that does answer your question. There's another question, and this one goes to Douglas. Could you shed more light on how effective the remote monitoring system has been working in South Sudan? In the context of South Sudan, I imagine it could be a real challenge due to poor internet connectivity and communication networks. So Douglas, over to you.
Thanks, Michelle, and thanks, Okech, for the question. Yeah, I know that we've got poor communication network, but at least for the facilities so far that have been installed, we see that we are getting real-time data. The problem will be in facilities that probably don't have the network. So probably we need to think about that. But at least currently for the facilities that have been installed, the information is coming in. We haven't yet reached to the facilities that really don't have that poor network. Thank you.
Great. And to Brigu in Lebanon, there's a question on, with all the electricity challenges seen in the country, how has this affected routine immunization coverage?
Thank you, Michelle. I think this is one of the major things. So just to answer it briefly, there has been a 30% drop in immunization coverage. The routine immunization program from 2019 to now has dropped in 30%, and this 30% is national averages. There are many areas with vulnerable population where the drop has been much more extensive than this. So it has impacted, and it's not just an electricity crisis, it's an economic crisis. People are not able to reach the facilities are not able to run. So all those has impacted in the entire immunization program.
Right, and we have another two questions, well, a two-part question, and it's for both South Sudan and Lebanon. How do you engage local service providers to maintain these equipments on a regular basis? And then what is the responsibility of the community or the health facility in this solarization project? So if either Douglas or Brigu want to take that.
Yeah, thanks, Michelle. I'll take on to the questions. One is in terms of the responsibilities of the host community or the health facility. So in terms of the solarization, of course, one of the things that I forgot to mention is community engagement, because you know that in Africa, most of these panels are like hot cake. So some of the solar fridges in South Sudan were vandalized because of the war, and people stole the panels. Before the installation takes place, the community heads sit together with the company that is installing. Then we agree on the safety of the equipment. So there's some kind of community policing, because this facility doesn't only benefit the staff around it, but it benefits the whole community. So there's policing, self-policing of the equipment, and they are given some light to show them that this equipment belongs to the community, and we are handing it over to the community. So in terms of security, the host community plays a very big role in terms of the host community. In terms of the health facility staff, on the solar equipment, there's what we call the daily maintenance and periodic maintenance. So the people that are doing, the suppliers that are doing the installation, provide the daily maintenance tips as well as the quarterly maintenance tips. For example, like cleaning of the panel. This is something that doesn't need money, because you use fresh water, no soap, nothing, and the battery terminals. So these small tips that are given to the health facility staff, and they play a big role to ensure that the solar system remains running in good condition. So probably I will hand over to my colleague if he has something to add on. Thank you.
Thank you, Douglas. No, I think the situations and things that you said resonate here also. We have a good local service providers and a good solar market that has developed because of the energy crisis, and therefore we are engaging the local service providers. And as I said in my presentation, we are not just doing solarization of facilities, which is our one kind of intervention. We are also working with the solar cold chain equipments. So we have engaged with the local service providers to ensure that if there is a breakdown, if there is a maintenance, the services are provided. But as you said, we are also engaging with the facilities to take on the responsibility of the preventive maintenance, which forms an equally important component in the entire solarization piece, to take care of that equipments and take care of those pieces. And in the host communities, I would like to flag two things. One is, it is not just the responsibility, I will not repeat what Douglas said, but also in the host communities, it is developing the confidence on the immunization program. What we were facing, the challenge was the host communities said, why should I come to a PHC which is already in the dark? Your vaccines will be spoiled, your services will be spoiled. So how can I trust your vaccines when the entire facility is in dark? So this solarization is providing the host facility or the host community a very big confidence that the vaccines are safe in those fridges and the services are being provided in this. So it's a host community common intervention, which is also helping increase the confidence of people again to the primary healthcare centers to come and get their vaccines and trust that facility. So that is how, beyond the other pieces, host communities is interacting with the entire solar management system.
Thank you very much, gentlemen. So there's another question in the chat that's quite interesting. So Yakubu says that there's no better option to alternative energy, particularly with the increasing costs of fuel, which I think we all can agree, but also with the demand of solarization, he feels that prices might increase, and asks if we have considered other sources like wind energy or so. And I think I'll ask Ranjit to complement here, but I think the important thing here is that we do operate within the UN structure as well. So while UNICEF, we're really looking at this as a strategy to reach zero-dose communities. This is part of our primary healthcare strategy. So solarizing last mile facilities. There is also large energy projects that are implemented through structures and organizations like UNDP, and they look at those kind of big energy projects that really feed into national grids, etc. Whereas we're looking at smaller scale projects at community level. So I think there is a big differentiation, because these large wind projects, etc., they're very, very expensive, and they're large infrastructure projects and not really under the domain of health, but more your energy ministries and departments within the government structures. So a very different operating environment, and a little bit outside of UNICEF's mandate. So I hope that answers your question. Ranjit, if you want to supplement on that, or did I answer that okay?
Sure, you did. You did cover the entire, the view of UN and the costing. Just one thing on the solarization, the cost of solar package is still very high today. I mean, it's just because the production is low. It's not at par with demand. So as the demand is going up, production will improve and cost will further go down. This is the trend. And of course, cost will start increasing only when the raw resources to produce these units are scarce. So at this moment, the production is, just a simple answer is, production is under par. There's a huge potential. With demand, the cost will go down for now.
Thanks, Ranjit. And there's a comment in Sierra Leone, the solar system were housed in health facilities. So the health facility received free solar energy, but the community pays for the use of the energy. So a service provider is selected for preventative maintenance, and the funds are collected collected is used for maintenance of the solar system. So just a suggestion in terms of an approach. That sort of contribution to the grid and community utility of the energy services, which I think is something that in some countries is being discussed as well. So thank you for that contribution. And then there's a question from Felix. In Lebanon, it is obvious that there is a high patronage of the private health facilities in immunization. What is the plan to solarize the private health facilities, especially those that may not have standalone facilities? Brigu?
Thank you, Felix. I think that's a very relevant question in context of Lebanon. So in Lebanon, there are two kinds of private sector providers, if I may. One is a full pay and a private sector, a private doctor running his own clinic, where you pay for your full services. We are working with this entire private sector to bring them into the loop of the national program and to join and collaborate. But in those cases, we are providing them not with solar equipments or solar fridges, but this is an investment where we are now working with the vaccines commodities as part of the intervention. The second private sector, which is not a for-profit private sector, which is the NGO-run facilities, and we have huge amount of NGOs who run the primary healthcare centers, and these NGOs partners are part of our network, which are being provided, some provided with solar cold chain equipment, and some provided some will as part of the solarization process, because these are non-for-profit private sector or the NGO sector who runs an equal share inside this. So yes, private sector is working very closely with us because the problem is for the entire country and not just for one domain. I hope that answers.
Thanks very much for that one. Here's another question, and I think it's a little outside of the primary healthcare and solarization discussion, but very relevant, I think, to cold chain and to why we're here today in terms of accessing zero-dose communities. And that is, aside from innovative cold chain storage approaches, what approaches have been considered for product choices? And is solar equipment being developed with consideration for larger orders? So, for example, measles and yellow fever vaccines are notably examples where coverage get impacted by healthcare worker hesitancy to open tenders vials due to fear of wastage. Without needed to make any dramatic changes, countries could order 5-dose instead. Healthcare workers would be more likely to open the 5-dose vials for a smaller number of children, and so coverage increases. However, 5-dose vials require slightly more cold chain space. And I think we released together with a number of other organizations a pager on this, particularly on measles, a fact sheet. And I think it is very relevant in terms of this, and I think in particularly in CCOP applications, there is this that is included in terms of what are the different strategies for reaching zero-dose communities, and including the type of vial size, etc., that are calculated in that too. But there are other complexities as well in terms of if you're just using this for one area or community, then managing two types of vial sizes in a supply chain, etc. So I mean, I think there are a lot of considerations, there are a lot of advantages to this as well, but I think it really is about health worker training and a lot about and processes and protocols and so on as well, and a lot about the communication out there too. But just to say that those 5-dose vials are available and countries can forecast for them and plan for that as well. So I mean, I think that is something that is very, very important, because you still see that health workers are scared to open that vial. And I'm sorry, I'm picking on you here, Nicholas, but I mean, you also have quite a bit of expertise in this area, if you want to comment on this as well.
Thank you, Michelle. No, I think you have said it all. There's very good evidence that that using 5-dose vials does increase the likelihood that health workers will open a vial for just 1 or 2 children. I think the additional cold chain space that is taken is very, very small, and at the facility level really doesn't matter. So there are many, many advantages with this, and what the studies also show is that because you reduce overall wastage, that there is no net cost increase in switching to 5-dose vials. So there's really a win-win situation in doing that. Over.
And I think we are intending on releasing the some of the answers to the questions, and I think we can also release the fact sheet on this that has a lot of the information that Nicholas and myself have referred to as well on 5-dose vials. There are 2 hands as well, Alex. Can we take questions from the audience?
Sure. So I don't know who raised the hand first, but I'm going to start with Faustin. Faustin, you should be able to unmute yourself and speak. Go ahead. Faustin Segla. Faustin Segla. Yes. Can you? Okay. So that was an old hand, it seems. So let's see with Babson Ilo. Babson Ilo, also old hand. So we have no more hand.
Okay, all right. Well, it looks like those are the end of the questions. There was just one more, and I answered it in the chat as well, around integration and the fact that there is still with regards to including oxytocin, insulin, various antivenoms and so on into the vaccine supply chain, that there is that risk of it being mixed up with vaccines. And I had answered it in the panel that I think the main challenge here really is and the root cause is really the load that there is on health workers and on health worker training. And integration really needs to be done, I think, very safely, and with that we need to make sure that health workers aren't overloaded, that they are properly trained, and that we have very good, or they have very good SOPs and practices in place. And there can also be other physical separation methods like separate shelves or boxes within the fridge as well, instead of a separate fridge, as well as good labeling to ensure that there aren't these kind of mix-ups as well. But I think we also do need to address the root cause as well, to make sure that we do have everything that's available at the health facility as well. I don't think there are any more questions, so I think with that, Olamide has asked me to wrap up because he is sitting in Sierra Leone and his connectivity isn't great. But I do want to thank the presenters for an excellent job and very interesting presentations. Also want to thank everyone that joined today, and particularly those that asked interesting questions and made some interesting comments as well. And then I also wanted to make sure, wanted to emphasize a couple of points as well. And that is essentially that supply chains are critical to catch up and recovery, and is central to both UNICEF and partners' mandate to reach zero-dose communities. and that appropriate leveraging of multi-sectoral approaches such as MNCAH, WASH, through integration, solarization is important for success, especially at scale, and that it is critical to have strong M&E components in implementing supply chain interventions. Appropriate collection of baseline and intervention-related data is critical to show how supply chains contribute to reaching zero-dose communities. So with that, I can give you a couple of minutes back of your day, and thank you very much for this excellent, excellent contributions and interactions. Thank you.
Thank you very much. So I think we can close this session. Yeah, I'm sorry that our colleague Olamide. Olamide, you here? Would you like to say your last word, if you can? Maybe not. Okay, I think Olamide unfortunately had some technical issues with his internet. So we wish you all a very nice day. We will send you the presentation as well as the link to the recordings in all languages. In the meantime, have a wonderful evening or rest of the day, and we hope to see you again soon on the Zero Dose community or on the TechNet 21 community. Bye, everyone.
Thank you.
Thank you. Bye.
Thank you. Bye-bye.
Thank you all. Bye.